Hello and welcome to today's department's COVID forum and entitled Community Resilience and Response Task Force. My name is Melissa Stiles. I'm Director of Family Medicine, Faculty Development for the Department of Family Medicine. And just a few housekeeping. One, if people could mute their mics. There's a few people still that have their mics on. And as we go through the panelists and the talk today, please write your questions in the chat and we'll have questions at the end. But feel free just to start the questioning right away and I'll keep track of those and join at the end to help moderate the questions. I'm very pleased to introduce the leader of the panel today is Shelley Shaw. We're so pleased to have her in the department. She's the Associate Director of the Office of Community Health, has a breadth of experience in public health from working as an infectious disease epidemiologist to community-based intervention programs that focus on keeping kids healthy and active. Underpinning all of her work is a deep commitment to racial and social justice, and she currently has been on the department's Diversity, Equity, and Inclusion Committee, and also on the Community Resilience and Response Task Force for the state. So Shelley, thank you so much for leading this, and she will introduce the participants.
Thanks, Melissa, and thanks everyone for joining us today. It's really fun to, even though I can't see you well, to kind of scroll through the participants, and definitely missing so many of you. So thanks for joining us today. I'm really excited to be able to introduce to you all an exceptional group of people who've been working to not only advance an equitable response to the COVID pandemic, but also really working hard to reimagine what could be. So our team, the Community Resilience and Response Task Force, has decided to introduce ourselves as we go through the panel today, but I am to be able to introduce Paula Tran-Inzio. Paula is the Mobilizing Action Towards Community Health, or MATCH, Director at UW Population Health Institute. What Paula is really to me, though, is a tireless champion of health equity. She's not only someone who has always been doing this work as long as I've known her and is living the work, but genuinely mobilizing more champions to advance this work together. So really lucky to have Paula leading this Community Resilience and Response Task Force, and I will hand it over to you, Paula.
Thanks so much, Shelley. You didn't prepare us for such heartfelt introduction, so appreciate being here with you all today and want to just acknowledge all the work happening likely across this participant on the response. So I get to lead us off. On the next slide, you'll see an image of where we've had the opportunity to work. So as Shelley said, we staff up the Community Resilience and Response Task Force. This is done by invitation by state response leaders. And you'll see once our slide catches up with us that since February, a lot has happened in our state and globally related to the response. In February, we had our first case, first individual that tested positive in Wisconsin. And then shortly after, the executive order from the governor's office declared a public health emergency and really directing the Wisconsin Department of Health Services to lead up a fuller response that brought us to a level 1 response. That means all state agencies were activated to participate in the response. This is a look at the response floor over at the Department of Military Affairs, where we were in person for several months. We have since gone fully remote as a response, but this is sort of a look at the action of what a level 1 response and mobilization looks like. On the next slide, just wanted to offer a few of the overarching goals related to the response. So some of the obvious things, I think, although maybe not so obvious sometimes, is that the hope was to really prevent the spread, and then what quickly then came to reducing the spread of the virus early on and continuously throughout the response, an eye towards healthcare system capacity, knowing that several of our health systems in the state and across the country weren't quite ready for what might come if indeed the cases surged to the point that our hospitalizations across the state would be required. So a great deal of effort has gone into assessing our capacity as a state and also really ramping up the potential need to surge throughout the state. In addition, the state response really worked to procure and provide resources to state and local healthcare and social service providers, including public health. And this included procuring personal protective equipment in a time of great shortages, as well as other materials such as hygiene products and sanitation products. On the next slide, this slide has been updated several times, but wanted to offer this just as a peek into sort of the complexity of the response. So you see here in the context of this particular public health emergency, the Department of Health Services, DHS, was called to be the lead in partnership with the governor's office. And there was a large team of folks, including several legal members of agencies across the state that were mobilized to participate in the response. For those of you that are familiar with emergency preparedness and emergency response, a couple of the classic sort of org chart boxes that you might find include operations, those that keep the flow of the work moving, logistics, those folks were really pulled together around procurement and acquisition, making sure our warehouse was appropriately stacked or strived to be appropriately stacked, as well as distribution, and then planning and finance, some key components of the response. These functions continue to exist today, and where we are currently is thinking about how to transition into a longer term, more sustainable response, knowing that there are many months ahead of us yet in this response. So DHS is working to reconstitute several of these functions within the Department of Health Services while maintaining tight and close connections to other agencies across the state. On our next slide, you'll see, and Shelley alluded to the wonderful team that we've had the privilege of working alongside. So you'll hear from several of us today, but we've been really thoughtful in terms of trying to consider, especially as our charge in a moment that TR Williams will be describing, to think about equity in the response, to really consider what we need to mobilize today immediately across agencies, as well as how do we set the stage for ongoing sustained work in this area. So really looked at engagement with the governor's office and key anchor institutions outside, in addition to the Department of Health Services, as well as outside of the Department of Health Services. So within the Population Health Institute, Shelley in the context of her work at the Department of Family Medicine, as well as thinking about key programs to engage across the department. I don't think we'll be hearing from Maggie Northrup today, but she leads up our state health plan, and that's where we want to continue to see sustained partnerships for the response, but also long-term across the various sectors that we've been engaging, as well as within extension. So we feel really fortunate to have been able to engage several anchor institutions to leverage the assets of the university in support and in service to the state effort and the response. So with that, I get the privilege of handing things over to TR Williams, the Deputy Outreach Director with the Governor's Office, who has been a real tireless, again, advocate of equity and making sure our state leaders are living up to the values that we espouse alongside of this response effort.
Thank you, Paula. Good afternoon, everyone. For those who may not be seeing the slides, but just dialing in, I always like to make sure people hear clearly that my name is T.R. Williams. That's T like tornado, R like roller coaster. And I do serve as the Deputy Outreach Director in the Office of Governor Evers, and have been honored and excited about the work happening with Team CERTIF, the Community Resilience and Response Task Force. To give you sort of our elevator pitch of what the Community Resilience and Response Task Force is and what it does. And though you all have the slides, I think it's worth edifying orally, as we have different type of learners as well, is that the CERTIF team, in collaboration with Resilient Wisconsin, which is a branch of DHS, the Community Resilience and Response Task Force aims to integrate concepts of community resilience, equity, and mental health across the COVID-19 pandemic in order to set the stage for future emergency preparedness infrastructure. And so under the SEOC context, we were known as Future Operations Branch or Team or Mission Checkmate. And the idea was that we certainly needed to have a rapid assessment and a rapid response to COVID-19. But we also, in those moments of bringing our head above water, needed to be planning for the future. And that we always couldn't be in the state of right now in this moment, even if that future was simply 72 hours. And so the Community Resilience and Response Task Force, in understanding that there was an opportunity and a very, I would say, historical moment when we're talking about the impacts of a pandemic on our society and our structures, to focus on the future, so that in us planning for the future, we are planning to be stronger, more resilient, and we also are planning to be able to not necessarily fall into the same gaps that we currently find ourselves in trying to respond to COVID. And so when you hear that language of integrating community resilience, equity, and mental health, those are priorities of values of focus to believe that would allow us in the future, as like I said, sometimes defined as simply 72 hours from whatever fire is happening at the moment, to be able to build a stronger community, a stronger Wisconsin. And so that said, in a different way, is that the objective is to strengthen individual and community resilience of groups who are vulnerable to disproportionate harm by the pandemic. This work is done by enhancing sector-wide partnerships and providing infectious disease management expertise, resources, and support. And so sometimes people ask specifically about the focus on groups that are vulnerable to disproportionate harm. And when we use that term equity, and we're talking about this group, sometimes it's seen through the lens of just sort of being good-hearted, right? Of focusing on those who are struggling the most. But really at the core of equity work and at the core of the CERTIF team is understanding that the groups who are vulnerable to disproportionate harm in a pandemic are the same groups who would have been vulnerable to disproportionate harm outside of the pandemic. And the pandemic exacerbates that. And in the true way in which we create our system, when you have that vulnerable population that is in such turmoil during a pandemic, the truth is that even outside of the pandemic, there is turmoil. You're not going to be able to have a broader community that's more resilient and strong without really addressing those groups that are vulnerable. So yes, everyone on the CERTIF team has a good heart and are good people. But the concept behind this work is that in focusing on those groups and really looking at equity, you are also preparing for the entire state to be able to be stronger and more resilient as we all combat COVID-19. The next slide I'll just set up, and then I'm actually going to allow the team to jump in here. There are three major areas of support. Sector support is the language that we use in CERTIF, that our work of resilience, mental health, and equity really focuses on. Those three sectors include populations living in congregate settings, which can include individuals who are incarcerated, those who are in long-term care, assisted living, or community-based care. Secondly, the sector of support is really looking at just recovery for residents with functional and access needs. This sector or this work includes the work of racial equity, rural equity, spiritual leaders, interpersonal violence, mental and behavioral health, as well as individuals with disabilities. And the third sector of support that SERTIF really hones in on in the work that we're doing is critical services workforces. So that's healthcare, public health, first responders, community health workers, migrant workers, as well as local community resilient efforts that are happening across the state. And so I will pause there to allow first our team on Congregate Settings. I believe we're going to have Carly and possibly Sabrina also chime in on that one.
Thanks so much, TR. And before we have our sector spotlights, we wanted to give a little bit of framing. So I'll ask, as TR said, we will feature 3 different sector support groups. Throughout the past 4 months, our team has been able to stand up about a dozen sector support partnerships across the areas TR just summarized, and wanted to offer this framework as scaffolding to sort of understand how we've approached the work and how we've thought about change targets. This framework might be familiar for some and new for others. This comes out of the Bay Area Regional Health Inequities Initiative, a framework to really understand emerging public health practice, particularly around reducing health inequities. And you'll see on the right, downstream, what we call downstream efforts in public health, and on the far left of upstream efforts. And the hope when we're thinking about health equity, we want to span the portfolio of initiatives across upstream and downstream. And historically, much of our efforts as a nation has focused downstream, really investments in healthcare and assuring that we address mortality. And that has been critically important. And as science continues to evolve and emerge, we know that in order to address root causes of these downstream outcomes, we really need a distributed portfolio across these health factors, as well as these strategies, which you find in the bubbles, the orange and teal bubbles below the boxes. Our work within SERTIF has been to take these priority areas that TR summarized, really rapidly identify where there are existing partners, and if there are not existing partners, where can we convene partners to really think about what is the opportunity today to embed equity in the response, but also to set the stage for a more just world post-COVID, a more just recovery, knowing that many of these inequities existed before. So we'll feature 3 different sectors that we selected, not because they're more important than the other, but we thought they were really great opportunities. On the next slide, you'll see what we wanted to seed here, opportunities to embrace this deeper connection between primary health care and public health, which has been an ongoing reflection for us as we are deeply embedded in this response, where we within the public health proper side of the world, as well as across community-based organizations and agencies, can be in deeper relationship with healthcare and in particular primary care. So the sectors that we've selected for you today offer examples of what that can look like, and we hope this can help seed ongoing conversations within the department to continue to think about the role of healthcare and in particular primary care in the context of this response, but also just advancing the public's health and health equity more broadly. So with that, I will hand it over to another wonderful colleague, Christy Anderson, who will talk about one of our critical services workforces.
Thanks, Paula. So I have the pleasure of sharing a little bit with you the work that I've had the privilege to sort of walk alongside over the course of the past 4 months in partnership with the Wisconsin Farm Workers Coalition and Family Health La Clinica. Just for context, Family Health La Clinica is the only community health center in the state dedicated to serving the migrant seasonal ag worker population and have been doing so for decades. So they were sort of really well positioned with deep relationships across the state to jump into and really lead this response from a lens of knowing a lot of the players and having sort of existing relationships with a lot of the players needed at the table to make sure that migrant seasonal egg workers' needs around health and safety were centered in this response. For context, there are just under 10,000 migrant seasonal egg workers that come to the state of Wisconsin every year for our growing season. So that starts in sort of late spring and moves through the cranberry harvest season in sort of mid-fall before the heavy frost hits in our state. An incredible amount of the canned food in our country comes from our state, and these workers really are the backbone of our nation's food system. They travel here sort of away from their families and away from their sort of critical community supports to make sure that our nation can eat. And so making sure that this essential workforce had sort of a plan around what it would look like to keep them safe in both their housing settings and their workplace settings was really important as soon as COVID arrived in the state of Wisconsin. When COVID got here, when COVID got to Wisconsin, Family Health Clinica was awarded a grant from Advancing a Healthier Wisconsin Endowment in partnership with the Medical College of Wisconsin to sort of take their existing model of healthcare, which includes both on-site clinics and a mobile healthcare unit that was already serving the migrant seasonal egg worker population, and expand that to be a COVID-specific response unit. So they immediately stood up a COVID-specific steering committee in partnership with the Wisconsin Farm Workers Coalition and started sketching out resources related to both employer and worker education and training. So how can we sort of come up with a shared understanding of exactly what this virus is and what we can do to keep ourselves, our families, and our work sites safe? They started focusing on what kinds of modifications needed to happen in both housing settings and workplace settings, knowing that both in housing and workplace settings, those are environments where sometimes folks are unable to physically distance. And so the more that we could do proactively before workers arrived to make sure that bunks were separate and sort of where possible work bubbles were 6 feet apart from each other, folks had masks, all of those kinds of things, top priority. They developed both tools for employers to use and offered worksite walkthroughs one-on-one with their staff to sort of answer those sticky questions like, oh, what about this particular piece of equipment, or what could I do here in this sort of really small space, and sort of troubleshooting in partnership with folks. They developed resources in close partnership with their local public health officers around isolation strategies. So if someone did get sick, what were the steps that they could take immediately to make sure that that person could isolate safely? And then finally, making sure that all of the work that they were doing around COVID was also taking into account the broader healthcare needs of these workers. So not only having conversations with workers when they arrived about how to keep themselves safe around this virus, but also how to appropriately manage other diagnoses that they may have, or what to do if they got the common cold, right? So they were establishing folks, as they have in other sort of parts of their work, into a MyChart system, a telehealth service, so that if workers did get sick with COVID or otherwise, that they had the medical support that they needed to take care of their health. Since the early days of the pandemic, Family Health Clinica has provided testing services to 2,000 migrant seasonal egg workers. And I think one of the narratives that we heard about this particular group of workers, given that they are sort of coming to Wisconsin from other states or from other countries, was this sort of fear that folks would come to the state with COVID and bring with them sort of a risk of outbreaks. And what we know now, we have data to confirm, is that migrant seasonal egg workers overwhelmingly, when they arrive in Wisconsin, are not testing COVID positive. So these folks are arriving in our state and have done an incredible job before arrival of making sure that they're taking the precautions necessary to protect themselves and their families. So Family Health Clinica now has the data to refute that negative narrative that has really sort of been driving and othering in both the press and sort of in informal spaces around this critical infrastructure of workers. Beyond that sort of early work, now that they are sort of in a groove, this group is in formal partnership with the state, leveraging National Guard resources to expand their testing capacity. They've been pulled into outbreak support. So even with settings where they haven't had an early relationship around prevention, they are happy to step in as a trusted resource to help navigate everything that is sort of involved in an outbreak setting. They're in partnership with folks like UMOS and Legal Action around how to make sure that workers' rights are still sort of centered, even when some of the kinds of services that those groups were providing in person may be slightly disrupted due to COVID. They are translating their resources for migrant seasonal ag workers to other ag sectors like the dairy industry and others to make sure that what they've learned is spread across the state. So yes, a lot going on in this space. And I think, Shelley, one of the things you asked us just to sort of mention was what's sort of different about this approach and what's sort of special about it, and what in particular, what made it sort of work. And I think I shared at the beginning, but Family Health La Clinica's leadership here is just an incredible testament to why building deep relationships and partnerships in communities is so critically important all day, every day, not just in a moment of urgency, but so that when a moment of urgency or a crisis arises, you're not trying to build relationships in an environment rooted in sort of fear and anxiety, but you're leaning on authentic and trusted partners. And sort of the pace at which this group was able to stand up these supports is a testament to the existence of those relationships. Last, I'll just share that the groups that have been involved in the coalition are listed on the slide, and I'm happy to share the website after this presentation is over for all of the resources that this group has developed if you're looking to learn more.
Thanks so much, Christy. And I think the critical part for this particular partnership for this healthcare leader was that it was never a question of if, but how. And I think for those that are really trying to forge those relationships between primary healthcare and public health, that's actually been a really big barrier to understand whether or not this public health prevention work is indeed a part of the mission of the healthcare system. And that was never a question for Family Health La Clinica, which I think has made them invaluable partners in this response. So next we have Carly Olson that will be talking about our collaborations with folks to really help prevent disproportionate harm to those that are currently incarcerated.
Yeah, thanks, Paula. So happy to talk about this. And I just want to first share, when I joined the task force, I had no previous work experience working with Department of Corrections, our prison system, and jails, and I have learned so much in this short time. And it really just goes to show how the value of partnerships and getting the right folks in the room can move things along and building those trusting relationships. So yeah, so like Paula mentioned, one of our sectors that started very early in the response is centered around Department of Corrections and our prison system. And for the sake of time, I'm going to focus on our statewide prisons and less so on our county jails, but we are doing some work with the county jails in similar form to what we've been rolling out with the prisons in the state. So just to note that is going on. But anyways, so as many of the folks on the line may imagine, you know, those who are incarcerated are at a huge risk of contracting COVID. And if you've been paying attention to the news, you've seen some of these really significant outbreaks happen in other states. And I feel really lucky that we've had some, you know, cases, and also it hasn't been in the same way as other places, but that does not mean that we stop pushing forward and preventing the spread and participating in that containment strategy. So yeah, so we right away at the beginning of the response partnered with DOC, and Dr. Sabrina Murphy and Dr. Geof Swain really served as key advisors in the process in helping us develop an assessment tool. And essentially what the assessment tool did was it really prompted folks working in the prison system to think about things that maybe they wouldn't have otherwise, like what will you do if you have a huge outbreak? Where will you isolate people? How will you test people? All of these things that require a huge amount of muscle to get off the ground, and prompted folks to think ahead versus panic on the back end. And so each prison in the state of Wisconsin has their own assessment tool completed and filled out about, what their plans will be, in addition to their pandemic plans, which they all already have. So those two tools work closely together to lay out how they would respond. In connection to those tools, the Wisconsin National Guard participated in site visits with all of the sites to help walk through what needed to be documented in those tools and ask those key questions. And then once that was completed, which really was, I feel like I'm brushing over, but a huge endeavor to do this at all the different prison systems, then we held a webinar where Dr. Murphy walked through some of the main themes and concerns around what folks needed more information on. And it was just such a great way to center her work in putting together the tool and providing that technical assistance, as well as, I think she did a great job as serving as a resource for folks and being able to have people ask questions that, maybe they feel like they're simple questions, but she did a great job just being there and helping them understand how to be prepared. I think right away when we started working with DOC, I heard a lot of sentiments around, well, wouldn't folks in an incarcerated institution be safe because they're not, in the community? And we know that that's just not true, right? The employees would be the ones bringing in the illness, and then it just spreads like wildfire. And so it seems silly, but I use a marker of success as now in our continued work to implement widespread testing and ongoing testing. I'm hearing DOC folks say things like, we're going to center employee testing because we know that they are the vectors for disease into the institution. And to me, I was like, holy cow, that is a huge shift in understanding how we approach this work, right? Instead of kind of being lured into this false idea that people are safe because they're not coming into the community. Instead, we're taking ownership over the fact that our employees are actually the ones who would bring it in and put these people at extreme risk for infection. Where we're going forward. So DOC is going to continue ongoing testing, routine testing, which is really exciting. But we know that that's only part of the containment equation. We're looking forward to possibly hosting another webinar to kind of prep people for the fall, whatever that means in the course of this pandemic. I think the pandemic has also shown us that, it's hard to predict the future. And also, we need to continue to be prepared and get folks the things that they need to prevent the spread and control the spread. Other things that I just want to highlight that I feel really lucky that our task force has centered some of the things like PR had mentioned, but we've also been able to offer perspectives on how important it is to continue social connection for folks that are incarcerated. And many places have stopped the ability to have visitors, but continuing to encourage video conferencing with family members and or having some limited kinds of programming if possible, so that folks still have that access to the social and emotional connection that we all need and we all feel right now in our lives. And so those are just a couple of examples of where we're going from here. But it really has been a great experience in thinking about how we partner and center public health, our physicians as our key advisors, as well as the Department of Corrections and moving forward. So I'll pause there and welcome questions at the end.
In true COVID-19 response fashion, we are covering a lot of ground in a very little bit of time, so please do jot down your questions for us. So Christy and Carly both featured some work in very specific sectors that we've been working in. I'm going to talk just briefly about just recovery. And again, wanted to draw on examples to uplift the role that health and healthcare partners have played, the first in the migrant worker space, sort of as leading preventive healthcare delivery, right, to prevent the spread and reduce the spread. The second with the Department of Corrections, where Dr. Sabrina Murphy and Dr. Geof Swain acted as technical advisors in infection control. And then in this case, really drawing across our just recovery efforts, drawing on our clinicians and faculty as advocates, which is another really important role as we toggle between immediate response needs as well as setting the stage for future work. So across each of the sectors where we did document the immediate need, like for example, in the corrections space, there was a need for direct assessment and testing technical expertise, while we also thought about some just seeding ideas on just recovery, such as the notion of decarceration, right? What would the world look like if our prisons weren't so full, which is a policy opportunity to really think about a more just, resilient community for the future. So throughout this process, we've done our best to model, and certainly can improve in a lot of spaces, but done our best to model, again, that holding what's equity in the response today while we sort of set these seeds for just recovery. So across all the sectors, we've compiled themes and patterns. There are many that have contributed to longstanding inequities, such as around incarceration, such as education, as we're seeing very clearly now during the schools planning and reopening debate, and working with clinicians and faculty and partners, including extension, to really identify opportunities for future policies and systems change that can allow for mitigations both immediately today through programs, but also set the stage for, again, policy work. And that's happening across worker supports and efforts. That's happening across our key social, economic, and environmental determinants and places where those resources are delivered, such as schools and in our communities, and have really valued the role that clinicians and faculty have played in the thought partnership, and will really rely on their role and power and influence to be continued champions and ambassadors of this needed change. I've just sort of offered a highlight there, hopefully as a teaser for ongoing discussion. And the Assertive team really wanted to show you from a sector perspective how we have partnered with healthcare providers, faculty, trainees, and now want to give some of the learners that we've been able to work with through this process a chance to talk about their experience.
Thanks so much for having us here. My name's Abby Boyk, and my counterpart is Becca Case. And we've been fortunate enough to work with the Assertive team and the chief medical officers on the Wisconsin COVID response all summer. Becca and I just finished our first year in the MD-MPH program at UW. So during the summer, there's a research program that some of you may be familiar with called Shapiro. And we were both connected with Dr. Westergaard as our mentor for that program. So instead of doing our own research projects, Dr. Westergaard brought us along to the Future Operations team at the State Emergency Operations Center in May. So our role on the team so far has been research and design support for different COVID-19 response strategies, protocols, and proposals. And Becca is going to outline a few of the projects we've been working on this summer on the next slide.
Thanks, Abby. So I wanted to offer a little bit about what we've been working on this summer, kind of a way to maybe bring about a brainstorming of ideas that maybe you see yourself in a role helping to collaborate with this effort. So one of the things that Abby and I took on this summer was creating a self-swab protocol for COVID-19 testing. This came about at the beginning of the summer, initially to review the process that the National Guard was using to evaluate if there was a way to reduce the amount of PPE being used. We went to the Alliant Energy Center and met with folks from the Dane County Public Health, and they had set up a really efficient and fluid testing strategy there. And so we felt it wasn't appropriate to change things at that point. They were running very well. But we did, through collaboration with those people, decide that there is room for self-swab in the future, especially maybe as we see more testing done in the clinic setting or in drive-up settings. And so Abby and I have been working with different entities within DHS to come up with a way to film self-swab videos and instructions for people from different languages, including Hmong, Spanish, and ASL. And another thing that has really taken on a big portion of our summer was we were asked by Dr. Myman to do a rapid review of the literature based on the role of COVID-19 in children. And this was back, I think we started maybe in the middle of June, maybe a little earlier than that. And obviously at that time, very little had been published or had been peer reviewed about the role of children. And so we did our best to really create this cohesive white paper to demonstrate what is known and what there are still questions about. And I think it really made it clear to Abby and I the huge challenge that our leaders and decision makers are facing with regards to the role of children in COVID-19. But that was something that we helped with the background research on. Abby, do you want to talk about a few more things?
Sure. Some of the more rapid turnaround projects that we worked on were research sprints on a lot of different aspects in the response. This usually included looking at the literature and looking at other states and nation strategies as they move through different challenges that COVID has presented to us. So one of the things we looked into were the metrics that different localities chose to put on their public-facing dashboards, both the metrics that they chose to share with the populations and those that they used to make decisions. We also looked into remdesivir and ventilator allocation, the ethical practices and processes behind these, and the guidelines that they were based on. And we also looked into the utilization of community health workers in contact tracing. This was a really interesting design that came out of Massachusetts. The population Partners in Health International, partnered with the government of Massachusetts to create a very integrated program that utilized community health workers as members of their contact tracing team to be able to better reach populations who were affected by COVID. And that research helped to inform a proposal by the Wisconsin community health workers to also be integrated into our contact tracing teams. Becca, did you want to talk about the last two?
Sure. So pretty much what was wonderful about this summer is that Abby and I were available and ready and willing to research anything that was kind of thrown at us. And we got better at it as the summer went along. And so throughout the course of the summer, we looked into the different mitigation strategies for reducing the spread of COVID-19. And I was able to assist a little bit with what Carly was talking about in creating a response, evaluating the different responses different jails across the United States are taking to reduce the transmission of COVID-19 as well. But pretty much it was very clear to us throughout the summer that there's a lot of collaboration that could be had and a lot of opportunities to improve the implementation of our COVID-19 response through involving learners throughout the process. And Abby and I had a really valuable and incredible learning experience this summer, being able to work on this COVID-19 response.
All right, thanks, Abby and Becca. Abby and Becca started their second year now, so we're already missing these two. I can't say enough about how much you've added to our work. So really already missing people. All right, trying to advance this thing. So this is a position paper that we share with our family medicine residents in our community health rotation. And in 2015, the AAFP came out with this position paper calling for the integration of primary care in public health. And so they stated that family medicine is poised to be the leadership specialty of the new culture of medicine. And so today we have shared quite a few examples, ways we're building stronger partnerships across public health and primary care, but I believe that role goes much deeper than the physician and the epidemiologist. So I think the COVID pandemic has really highlighted spaces where there have been a lot of good ideas in the past that seem to be insurmountable. But so we never really quite got there. So things like remote working come to mind pretty quickly. It seemed previously that was something our systems couldn't support, but when the call came, we made it happen. And honestly, when I say we, I'm looking at Matt and our IT team, because I feel like you all really rose to the challenge and made that work happen almost seamlessly for us. So today I feel like so much of this conversation has been about the physician and public health, but I'd really like to invite all of you in our department to be thinking about your role in advancing this work. Was talking with a colleague a while back about some of our other systems. Like one example could be that our financial system doesn't allow for co-PIs on our grants, right? We have a PI and we have a co-PI, but we don't have room in those financial systems to have shared partnership and leadership. So there are just a bunch of examples, I think, throughout all of our systems that reinforce traditional models of working. And so as we think about ideas like community-oriented primary care and working on the social determinants of health, I think we need to reevaluate the systems that we work in and ask if they're reinforcing the outcomes that we want. So that's the question I might leave you all with. I think Amber Canto from Extension may have some thoughts for you as well in this round.
Thanks, Shelley. Hi, everybody. Amber Canto. I'm with the Division of Extension and have also been working with the assertive team. And one of the things that I'll say, as we are a new division within the structure of UW-Madison, really interested in continuing to build out our own partnerships across campus, but also reflecting on our positioning and infrastructure within community spaces. And that sets up a really interesting opportunity for us to listen, learn, and work with in partnership of organizations and communities or subpopulations, however you want to frame it, around the state. And I think the other aspect of that, so one foot in community, but then of course our other foot is in academia. And one of the opportunities in this sort of broader public health and clinical partnership realm that I see is sort of bringing together the multiple different perspectives and grounding it within the academic frame currently in sort of identifying and flipping the framework of needs and perhaps research questions. Shelley just mentioned the PI ship, and would invite you all to sort of think about how you might expand the complexities of the frameworks and the engagement structures. And I know Christy said this really well in the presentation, and I think is really, really true going forward in this partnership realm as well, is doing the work now to develop those authentic partnerships so that they're there and the trust is established and the rapport is built, and the work can then continue from there versus building them in the moment when they come. And I think that's a really great lesson and opportunity for us to continue in working together through this equity lens. So I'll maybe end there because I know we've got some questions and opportunities for conversation and reflection.
Thanks, Amber, and thanks everyone for sharing. I might unshare my screen now because I can't see the chat, but Melissa, maybe I'll hand it back to you and see if there are questions that folks have for us.
Great. Thank you all. Really wonderful. And my hats off and amazing work in a short time to all of you. So I'll having a little glitch in the chat, but let me get the
Melissa, I can see
Okay.
some of the questions if you want me to go ahead and field the first.
Oh, thank you. That'd be great. For some reason I can't get it's it's frozen on me.
No
So.
problem. So the first question from Maria related to the medical residency for preventive medicine and public health at UW-Madison. So the preventive medicine residents have been a key part of the response. So Dr. Sabrina Murphy is a second-year resident, and we've got several of the first-year preventive medicine residents also part of the team. And Dr. Pat Remington has been an advisor to us. So have been really thrilled to partner with them, and really great to see graduates of the program on the line today. So the next question there, Wisconsin has a public health structure that is strongly based in each of its 72 counties. How has coordination and collaboration been from the state and local level in dealing with COVID-19 issues? There's a lot to unpack there, and not just 72 counties, but also several tribes. So that has been a really big challenge, and we have 50 states, and so the lack of a unified plan across the nation federally has certainly been felt statewide across our counties and across our tribes. So our state leaders are doing their best to be as coordinated as possible, but in the context of the pandemic, it has been a huge challenge to have what has been a patchwork of different ideologies, decisions, and policies and approaches across all of its counties and all of our tribes. So that's been a huge, huge challenge. I'm happy to keep going until others stop me. We got another question. Any work locally in Dane County working with the Latinx community? And others should feel free to weigh in if they would like. I know Shelley's very active in Dane County, and I myself sit on the Board of Health for Dane County. So because every county has a lot of local infrastructure, the Dane County response is run by Public Health Madison Dane County, our local health department, in partnership with several county agencies. And there's been lots of work to engage with the Latino Health Coalition, the health councils, and across the Dane County health collaboratives. And probably folks on this line could probably speak more explicitly into those partnerships than I, but I do know there's a lot of ongoing work and a lot of hopes to continue to strengthen those partnerships. I don't know if anyone else wants to weigh in and share. All right. The next question there, what steps are needed to sustain the work of the task force? So in general, the task force was really designed to sunset, that we were invited in to meet a really specific need. And our hope over the next 6 months is to really support the capacity of existing anchor institutions, the most primary being the Department of Health Services, as well as thinking about folks like Amber's work within Extension, how the Department of Family Medicine and the Population Health Institute as anchor organizations continue to work alongside. So our hope is that over the next 6 months, we get partnerships in a place that can be sustained by longer term efforts, such as through the state health plan. But we do hope, it is the intention for the task force to eventually sunset so that it gets further embedded into existing infrastructure. Happy to keep going unless others want to weigh in. Another question from Maria. In May, I was talking with an advocate for people and that are for those that are currently incarcerated, and he had no idea what was the plan for COVID and was very frustrated, and he asked many people and couldn't find someone who could answer the questions. Any plans to include more of the nonprofits and community advocates in the recovery response in general? I will say we have focused our efforts on statewide advocacy organizations and groups, knowing that we want to make sure to be careful of the local leadership capacity. So anytime a group reaches out to us, we try to engage the local public health officers as well as local leaders. So there have been efforts at the local level to engage community-based groups and nonprofits. And that being said, those efforts can always be improved. So if folks have questions, we're happy to help DOT connect. But there are some promising efforts and certainly much more that can be done. The team is dropping in lots of links here, so would draw folks' attention to the chat for additional resources for of efforts that are happening within Dane County, especially with the Latinx community. From Jennifer, will your team be working to support complex COVID issues with voting? So there is a separate task force that is stood up related to elections. So to the extent that that team wants engagement from us, we do contribute. And I know TR's team at the governor's level certainly engages with the Elections Commission, but the response itself has a separate elections task force that has dealt with some of the more nuanced and complex issues related to voting. Looks like we've got another question here. Just to clarify, I chair the Latino Health Coalition. I thought that was maybe true, but didn't want to say the wrong thing. And other than what we are doing, we have not had assistance from other organizations. Most recently, we are waiting for public health to partner. Absolutely. I think there's been a tremendous amount of work happening on the part of organized councils and committees and community-based organizations. And I know our public health leaders are experiencing a time like they've never experienced before. Because we have little statewide coordination, they are being faced with often recreating many wheels across many sectors, including community-based groups, occupational health, worker health, and largely most of the local guidance gets steered to them. So I'm not surprised to hear that maybe some calls for partnership have not maybe been heard, and it's not because our local leaders don't want to partner. I've never seen public health be surged to this degree. And so we are doing our best to help alleviate the burden on our public health leaders, and to the extent that we can help make direct connections or help answer questions or connect to resources, we're more than happy to do that if that feels helpful. So would really welcome that invitation, and always happy to try to alleviate some of the requests coming into our local leaders. We know it's a really, really tough time.
Oh, great. We're running up towards the hour. So we just, if there's still time for one or two more questions, if someone wants to put that in the chat.
Paul, I don't know if it's helpful to share, but I think just one of the sort of things out in the ethos that I think this response feels really big, and these sort of questions of what can we do, anything is helpful. And I think in particular, one of the sort of easiest things that we can all do is sort of continue to drive public support for our local public health infrastructure, and sort of anyone across the response that is sort of in that space where they're receiving a lot of heat. So right now, it's always local public health departments, but right now it's also our local school leaders, right? And so sort of being part of the group of people and communities that is out there saying, hey, these folks have an impossible job, and trying to sort of help people see what's in their own power to do and to sort of step into that space, just driving that local support and that sort of we have your back kind of mentality in your own spheres of influence is something really easy that we can all sort of take responsibility for when it comes to having sort of the public's health in our best interests. So I would just also offer that in this space.
Great. And we'll end with an easy one from Bill Schwab on addressing vaccine suspicion is a major concern going forward. And is the task force dealing with that, or what's your knowledge of the public health response in Wisconsin to that?
I was going to jump in, if that's all right, as sort of a continuation of Christy's comment and offer, yes, vaccine suspicion and vaccine hesitancy in general, major concern. It's on the radar, and there are groups in the response that are addressing that. And I would say an approach that we've taken in the assertive space that I would lean heavily on in response to this as well is identifying and engaging trusted messengers in support of the response. So who are the ones that people are going to be listening to and respect and trust in delivering this public health guidance and these prevention practices? And sadly, public health is not always the best messenger. And so I think family physicians have a role to play from a trusted messenger in support of vaccines. That's certainly something to lean into. And also, who are the other community groups or sectors that we can partner with to help support our messaging broadly? And there's a messaging question too. I don't think we meant, I'll just maybe also offer, we're working on some narrative tools that a part of a broader Healthy Estate effort that's been convened by Population Health Institute. And so we could probably share as follow-up some of those resources as they're developed and available on the Population Health Institute website.
Great, thank you. So, all right, well, thank you again. And Shelley, do you have any closing thoughts?
No, but just certainly welcome folks to reach out, especially to me. I'm happy to draw more connections. And I think even to Jennifer's point, how do physicians amplify some of these communications? There's so much work that we can be doing. And I see this as a really great opportunity to bridge public health and primary care. So would be more than willing and excited to continue to have some of these conversations offline.
Yeah, definitely agree. Hopefully the beginning of many conversations. Thank you all for joining us today, and hope you have a beautiful afternoon.